in a very renowned, the pink specialist, Dr. Sucheta Vanjari. To introduce her, ladies and gentlemen, she is a gold medalist periodontist who scored a record-breaking 81% in MUHS MDS in 2016. She is the founder of Revive Dental Pune and a leading expert in implantology and periodontal therapy. As a national speaker, she has delivered 50 plus lectures across various prestigious platforms and has also conducted various hands-on courses in implants and periodontics. Being a passionate mentor and a clinician, Dr. Suchita also is a founder of Soul Heal, a mental health initiative by her. She was also crowned second runner-up at Mrs. India 2020-21, an inspiration for all the ladies dentists out there. She holds 2 copyright for her innovations in dentistry and is also known for her dedication and excellence in the field of education. So a very warm welcome to you, ma'am.
Actually, she has a lot of achievements and she has kept it very short. Because 3 of them we have done together. This and all, so many conferences, so many lectures, so many hands-on courses she has done. So anyway, over to you.
Thank you so much, Dr. Sakshi, for introducing me so well. And thank you so much, Dr. Sudhir, for organizing this and for everything that you've like all the ways in which you've supported me in the past. So, without much ado, should we proceed with the presentation then?
Yeah.
Okay. Am I audible? Well, okay, okay. Okay. So, a very good afternoon to each one of you. I would like to thank Dr. Sudhir and his entire team of ADC for conducting such valuable sessions. He's been doing it since a couple of years now, and it's always gotten very good responses. So, I would like to thank each one of you for sparing a little time of your very, very precious Sunday to learning something about the pink. And I will make sure, I promise you that by the end of this presentation, you're going to have a better understanding of what the pink is and how to deal with it. So today the topic we're going to be learning is about the gingiva, and I am going to be presenting it in my own particular way, something that you probably wouldn't have come across in your textbooks when you were back in BDS or if you've done MDS in periodontology. So without much ado, let's begin. I will be covering today's presentation under the following headings. Now, um, it's a well-known fact that a lot of dentists, almost everybody, doesn't like perio. No, nobody likes perio. And if I ever ask my students about which branch of MDS they would like to pursue, they always pick something else. There are very few people who have picked perio. So that is a harsh reality of the subject. But it's also true that once you get into your practices, there will come a time in your practices where you realize that you need to know a thing or two about the pink. And that is why I get a lot of practitioners attending my webinars or my workshops, my lectures, because it's when you start practicing that you realize that you are absolutely clueless about the gingiva, the pink tissues, and you need to know. Now there are two scenarios that may happen with you in your clinics. Number one, can you just mute everybody? Yeah, thank you. So the number one scenario is a patient like this comes to your clinical practice, lots of inflammation, lots of findings, and you are absolutely clueless about what to do in this patient. And the other scenario is you probably do not want to treat the gums, or you probably have a periodontist on board, but You want to do good white aesthetic treatment, and then you deliver a nice beautiful crown, and this is what happens. So the reason why you will want to know about the pink is probably because you get a case which is a frank gingival or periodontal patient, or you may not have a gingival periodontal patient. You may want to perform a normal crown prep or a restoration or a normal routine procedures, and the pink gets in your way. So, before we move on to what we can do to the pink, let us first begin by understanding the pink. The harsh reality of the periodontium is that it is so unpredictable, and that is probably why a lot of us don't understand it. And that is why a lot of us don't like it, because it's so unpredictable. We are so used to the predictability of the white tissues that we cannot take the unpredictability of the pink, and that is why we try to escape it. So let us first try understanding how they work, and then we'll move on to discussing all the different types of procedures that can be done. To summarize it, in my opinion, I always state this and I will state it again: gums are like women. They are very relatable to women. Now, the qualities of the gingiva, or the main properties of the gingiva, are pretty much similar to the role a woman plays in a family. The prime being investing. Investing means covering. So the role of the gingiva is to cover everything, to cover all the structures below. And that is exactly what a woman of the house does. The role of the gingiva is to protect everybody, to protect all the other structures. And that is exactly a role a woman plays in the family. She protects her children and her family. Her role is to nourish everybody. So that is exactly what gums do. The gums not only cover and protect the tissues below, but they also nourish the tissues below. And I'm sure you will all agree to this, that the gums are pretty feminine. They're pink, and it is the gums that adds charm to the smile. You may have absolutely beautiful pearly whites, but if you don't have good pinks, your smile is not going to look good. So it is the gums that gives this charm to the oral cavity. So the gums are pretty relatable to women when it comes to the good aspects, but since they're like women, the good, the bad, everything is shared. Every time we feel that we've understood the gums, they misbehave. The gums are going to be so unpredictable that you won't know when the gums are going to react to any other treatment that you've done. And when they start reacting, the gums will become red, they'll start bleeding, and exudate will come out of it, and it will swell up and all of that. And if you don't treat the gums on time, the gums are going to reach such a point that they're going to throw you the tooth out of them. So that is how gums are like women. They have all the good aspects of it, but they are also very, very unpredictable. But that is why I'm here today. I'm going to be helping you understand how to plan your treatments when it comes to the gingiva. Okay, because when you know how to look after the gums are going to look after your teeth. Okay, so since I relate gums to women, I would like to say that it's always nice to have a wise woman and a beautiful, resourceful woman, a noble woman, a gentle woman, virtuous, righteous, charitable, and thoughtful, and everything. Okay, I'm sure every woman would want to be everything, but it's just so difficult to be everything at the same time. In my opinion, if a woman has three things, she is complete. Okay, so according to me, if a woman is healthy, happy, and loved or cared for, that makes her complete. And a similar analogy I would like to give to you about the gums. In my opinion, I am an advocate of the gums, the gingiva, the periodontium. And as an advocate of the periodontium, I would like to state that if there are three aspects that the gingiva has, that makes the gingiva complete. Now there are a lot of things you've looked at in your textbooks, and it's also confusing. So I'm going to be simplifying it by making these three things known to you. So when you look at your patients and when you look at the gums of your patients, try to look for three things. Number one, try to make sure that the gingiva is devoid of any form of inflammation. You know what inflammation is, and it's going to present as a redness and swelling and lots of other things, which we will be covering ahead. But if you know what inflammation looks like, your duty as a dentist is to try to make sure that the gingiva is devoid of inflammation. Number two, the gingiva should be sufficiently thick. When I mean thick, I mean to talk about the thickness, that is the buccolingual thickness of the gingiva, especially on the buccal aspect. Okay, so the gingiva is supposed to be devoid of any form of inflammation. It is supposed to be thick enough because only when it is thick, it is going to protect the tissues below. And the third virtue that gingiva must have is width. It should be wide enough because when it is wide, when I talk about width, I'm talking about the apicocoronal height of the tissues. When the gingiva is tall enough, high, when it is wide enough, it basically means that that part of the gingiva is attached to the alveolar bone. And it is also called as attached gingiva or keratinized gingiva that you must have studied back in your BDS. So when you have a good width of keratinized tissue, then only the patient is going to be able to keep their gums clean. That is only when the patient is going to be able to eat well and perform oral hygiene practices. So if the gingiva is wide enough, it is going to help you maintain the gingiva. If there is no attached gingiva, it becomes impossible to clean around the tooth. That is the importance of attached gingiva. So to summarize, it's okay if you can summarize all your findings under these three headings. It's okay if you don't know a lot about the gingiva, but make sure in your patients try to attain a gingiva that has no inflammation or minimal inflammation, that is thick and that is wide. Okay, if you've understood this, we'll move ahead. If you have doubts, feel free to post in the group, and I'll keep my chat box open. So if there are questions, I can immediately answer them. Okay, so the point number one we saw was gingiva should be devoid of any kind of inflammation. So, for that, now how do we make sure it is devoid of any kind of inflammation? To simplify this, I'm going to take you back to your BDS, third BDS case papers, case histories, where you would have your gingival charts. Okay, so let's go back to that chart because when you think in the aspect of the chart, it's going to make the whole pool of information simple for you. Okay, so like you must be remembering, we had color, we had consistency, we had contour, we had texture, size, shape, and position. These were the aspects, the features we studied back in our gingival charts in our case histories. Now we have to make sure that all of this is on point. Okay, what is the normal color of the gingiva? It is pale pink or coral pink. What is the normal consistency? It is firm and resilient. What is the contour? It's scalloped. What is this texture? It is stippled. The size should not be increased. The shape should have nice pointed interdental papillae and knife edged margins, and the position should be at the level of the CEJ. So this is what I just told you is what should be normal. And if anything is away from the normal, you are supposed to, as a dentist, try to bring it back to normal. Okay, now let's go ahead and dissect one by one. Color. So, like I told you, the normal color of the gingiva in health is coral pink. Okay, now you should know how the color of the gingiva changes and what causes that change. So, if you know what causes the change and how it changes, you will know how to get it back to normal. Okay. For example, normal healthy gingiva usually is coral pink, but of course, people have different levels of pigment in their gingivas owing to their skin colors. So that's a whole different thing. But on an average, let's consider coral pink is healthy when there is a little bit of inflammation. Now, see, gingiva has two major things, it has blood vessels and it has collagen fibers. I'm sure you know about this. It has a lot of other constituents as well, but let's look at these two major things, blood vessels and collagen fibers. Now, if the number of blood vessels increases, the color of the gingiva will change to something else. If the number of collagen fibers increases, the color of the gingiva is going to change to something else. Okay, so that is how every small change can affect the color in a different way. So let's go ahead and understand this. Now, when does the number of blood vessels in the gingiva increase? It increases in case of inflammation. So if the number of blood vessels is increased, that means the number of blood carrying pipelines in the gingiva has increased. That means the color of the gingiva is now going to be a little more reddish than normal. Okay, so if in your base coral pink inflammation has occurred, the gingiva starts looking reddish pink. Okay, as you all know, there are two types of inflammation, there's acute and there's chronic. Something that happens suddenly is acute, something that takes a long period of time to occur is chronic. So when it happens immediately, acutely, the gingiva does not get any time to settle. Because the gingiva does not get any time to settle, the color of the color of the gingiva remains bright red. Okay, why is it bright red? Because suddenly the number of blood vessels is increased in that area, so it looks bright red. Okay, now if the acute inflammation is not controlled on time, there is a possibility that the tissues there can get necrosed. If the necrosis means death. So when the tissue necroses, that means the blood vessels have all died inside. So there is no blood. So when you take blood away from coral pink, what is going to happen? It is going to start looking dull whitish gray because it's dead. I'm going to show you clinical pictures going on so that you have an understanding of how exactly what color looks like. Okay, so this branch of inflammation was about the acute inflammation. Now, chronic inflammation, like on the other hand, like you know, it takes a while for chronic inflammation to set in. So the gingiva has a lot of time to adjust. Now, when there is something happening very slowly, the blood flow in the vessels becomes very sluggish and it's very slow flowing blood. Because the blood flows very slowly, the blood remains stagnant in one position for quite a while. When the blood remains stagnant, the pigment in it called hemosiderin starts breaking down. And hemosiderin is reddish in color. Once it breaks down, it starts looking blue. That is why in chronic inflammation, you're going to have a little blue to the red. And that is how it becomes bluish red. Okay, so if you understand how these changes occur, you will know how it is going to present clinically and you'll know how to treat it. Okay, I hope this part of the inflammatory part is clear. Now, like I told you before, the two main constituents of the gingiva, blood vessels and collagen fibers. This lower branch was all about blood vessels, increasing in the number of blood vessels. Let's talk about what if collagen fibers increase. Now, collagen fibers are white in color. So if the number of collagen fibers are going to increase, it is going to mask the already present blood vessels. So if you have a red blood vessel and collagen fibers build on top of it, the color of the blood from the blood vessel is not going to be seen outside. And that is why the pinkishness of coral pink is going to dampen. That is why when you have fibrosis, fibrosis means the increase in the number of collagen fibers. When you have fibrosis, the pink now starts looking pale pink because the number of the amount that of the blood that is the intensity of the red color of the blood that is seen outside is dampened. Okay. Apart from this, what are the other color changes that usually happen? Hyperkeratinization. Constant irritation of the surface epithelium of a tissue will lead to a thickening of the keratin layer called hyperkeratinization. Keratin is dead tissue again. Dead tissues are always whitish in color, and that is why hyperkeratinized tissues are going to look white. A person who has higher melanin pigment in the gingiva, it's going to look brownish black. And in certain cases, you may develop that even if you don't genetically have a deep pigmented gingiva. If you have an underlying disease such as jaundice, you may have yellow presenting gums. You may have grayish blue color if there's metal pigment in your gums, or it could also present as slate gray, such as what looks appears in amalgam tattoo. So when we talk about the color, let's always understand how the color changes instead of trying to remember how what different colors can the gingiva be. If you understand how it changes, it's easy to get it back to normal. Now, quickly, I'm going to show you a clinical examples of all these colors so that you can get it register in your head how this color exactly looks like. This collage over here, I'm going to be starting from the lightest to the darkest. So please keep a track of the circles that are coming on the screen. The first circle that has come, that is how pale pink looks like. That is extremely pale, anemic. In an anemic person or wherever there's an increase in the number of fibers, that is how pale pink looks like. Okay, the second circle is how whitish looks like. That means it's pink, but it has a whitish layer or a whitish tinge to it, as it would be seen in candidiasis or any other condition. Now, the third circle is how healthy coral pink looks like. And I'm sure a lot of us Asians or us Indians don't have coral pink gingiva. We have a more of a coffee brown or a pink gingiva with pigment. But this is to show you how exactly coral pink looks like. Okay, now moving on to necrosis. This part of the interdental papilla, the one above the gingival margin, the yellowish deposits seen over there, that is how necrosed tissue looks. It's grayish yellowish, slough like. Okay, circle number 5 is jaundiced gingiva, yellowish tinge. Now pay attention here. Circle number 6. This this patient, this color over here is how reddish pink looks like. That means in pink, you've added a drop of red. Okay, this is how inflammation looks like, reddish pink. Okay, acute inflammation is going to look like this, bright red. So if you see something like this bright scarlet red, that is going to be acute inflammation. As long as you don't see anything so bright, it is not acute inflammation. Okay, now looking at the image, the bottom leftmost image, that is how chronic inflammation looks like. If you closely and carefully compare that circle to the reddish pink circle and the bright red circle, you will be able to understand that in this patient, in this gingiva, there is a small drop of purple or blue. So that is how bluish red looks like. That is exactly how bluish red looks like. It is red and pink, but it has a tinge of blue. So it looks more towards a purplish side. This is an example of grayish blue, slate gray, and the last one being brown or hyperpigmented gingiva. In our dentistry courses, we've always gone through the colors, but I don't know if you've ever really understood how the colors look like, and that is why I presented a color palette over here for you to understand. Okay, so that was about the color. You identify what color has changed and you bring it back to normal. Okay, I'm going to be presenting all the cases towards the end. First, I want you to have an understanding of all of this. Okay, coming on to consistency. Consistency is what you feel when you squeeze something. Okay, like you take a grape and you squeeze it. What you feel when you squeeze the grape is called consistency. The normal consistency of gingiva is supposed to be firm and resilient, like the image shown in the on the screen. If you have inflammation, instead of firm and resilient, it is going to start appearing soft and edematous. Okay, it is going to appear soft and edematous. So understand that in this patient, the color is also changed. The color, this is the same image from the previous slide. The color is reddish pink, which talks about inflammation. The consistency is soft and edematous. So this also talks about inflammation. If you touch it, it's going to bleed. These are the signs of inflammation. That tells you that this is frank inflammatory overgrowth. Okay. Now, this consistency of this other patient is, if you it looks, it's enlarged, but if you touch it, it does not bleed at all. Even if you scale around it, there's no bleeding. Why? Because in this patient, the enlargement or the overgrowth is not because of inflammation. It is because of fibrosis. So, this patient has had an overgrowth, a deposition of a lot of collagen fibers, so much so that it has gone out of shape, and this is how it presents as. This is fibrous gingiva. Okay, so the consistency of this is going to be firm and leathery. This feels like leather. So that is how you understand the differences. If you know the difference, if you understand the difference, you know how to treat it. The inflammatory enlargement has to be treated by removing the inflammation from that side. To remove the inflammation, you have to perform phase one, scaling, root planing, antibiotics, and observation, good oral hygiene. All those measures are going to help you get rid of that. Whereas the second enlargement is not going to get treated by doing any of that. So the treatment for the second type of enlargement, since it is fibrotic, is excision. You smoothen it out. I've shown the treatments ahead. Okay. Now moving on to contour. Contour is the shape of the tissues around the teeth or around a particular structure. Okay, like you all know, the contour, a normal contour of gingiva is supposed to be scalloped, like the one shown in the image number one. If this contour is the scallop is deepened, we start calling it accentuated scallop. Now, accentuated scallop occurs in gingival recession, like the image shown right below the tooth. Okay. On the other hand, if you have a gingival enlargement, the scallop is now going to be convex. So initially the scallop was concave, and now because of the enlargement, it has become convex. So this usually happens in enlargements. And wherever you have teeth missing, you're going to have a flat scallop, a flattened ridge, because a scallop is present only as long as you have your teeth. Okay, if a patient with normal scallop comes to you, good. If a patient with deepened scallop comes to you, your intention, your treatment should be in a way to try to reduce the depth of the scallop to bring it to normal. If you have enlarged gingiva, a convex contour, your treatment is going to be indicated to. The intention of your treatment is going to be to try to reduce it back to a normal scallop. Okay, so once you understand contour, you will know how to treat. Now, these six patients are examples of accentuated scallop. Okay, it's mostly going to happen in recession. Now, this first top left image over here of these two central incisors, you can see that there is a recession around 1-1. But here you are supposed to identify the cause behind this recession. The cause behind this recession clearly is this high frenal attachment. If you treat the recession without treating the high frenal attachment, your recession is going to recur. So you first relocate the position of the frenum and then you treat the root recession by root coverage. All the other patients are of recession to give you an idea of how accentuated scallop looks like. Okay. Now, these patients, these images, these 5 patients are examples of how reduced scallop looks like. So, you can see the shape over here is bulbous and the scallop has been reduced because the gingiva has grown down. Okay, so the first one is inflammatory. The second one is altered passive eruption. That means when the tooth erupts and it comes to its final position, the gingiva forgets to stop, it keeps on growing. It's a developmental thing, and when this happens, the teeth start looking short, but there's no overgrowth or anything over here. Okay, the third patient again is an inflammatory gingival enlargement, and the fourth and fifth are altered passive eruptions. Just to show you how, when the scallop reduces, how it looks like. And this is a patient where who has a flat scallop. So this is how reduced or flattened scallop looks like. Okay. If you have questions, please go on typing it into the chat box so that I can clear them as we go ahead. Okay, moving on to texture. Normal gingival texture, like you've studied, appears to be like an orange peel. So this is called stippling. This is an indication of health. Now, after a while, if the patient has inflammation, the stippling goes on reducing. So this plum skin that I've put here, the image of the plum skin, that is how reduced stippling looks like. And when it is completely gone, this is what it looks like. It looks like a tomato skin. So that the stippling has completely gone. When stippling is completely gone, that means the gingiva has some kind of underlying inflammation. Okay, moving on to size. Now, like we all know, the size of the gingiva increases when there is either inflammation or an increase in the size or an overgrowth. This image, the top left image, is an inflammatory overgrowth, like we've already seen this patient, and the top right is a fibrotic overgrowth. Now, like I told you before, the treatment for both is going to be different. The top left patient, the first patient is has inflammatory enlargement. So to treat that patient, you need to get rid of the inflammation. The the bottom left image, right below that patient's image, is is after treatment of the patient. Just doing a good phase 1 therapy has reduced the inflammation so much that this is what it has come to. Okay,
अच्छे ना आता है
so this is how inflammatory enlargements are supposed to be treated. Okay. The second patient, on the other hand, has fibrotic enlargement. So whenever there is
टेस्ट अच्छा ना
fibrotic enlargement, like I told you, doing phase one is a
Yeah.
part of. Can we please mute? Thank you. So, fibrotic enlargement. How do we treat fibrotic enlargement? We excise the tissues. Okay, so we've thinned out the tissues here by doing a gingivectomy and a gingivoplasty. So this is what it looks like after treating. So basically, the treatment of both types of enlargements are different. Okay, so once you know what has caused an increase in size, you're going to be able to treat it. Shape. The normal shape of the gingiva looks like this. It has pointed interdental papillae and it has sharp knife edge gingival margins. Okay, pointed interdental papillae and knife edge gingival margin. This is how healthy gingiva is supposed to look like. If there is inflammation, the the interdental papillae start becoming bulbous. These are bulbous interdental papillae. Okay, and the gingival margin is not knife edged anymore, it's rolled out. In this second case is a case of necrotic gingiva in which the interdental papillae have been lost or flattened. So these are the changes that can happen to the shape of the gingiva. Okay, so what we saw now was how, like, the factors which you can assess to make sure your gingiva is devoid of inflammation. Now the treatment for that you is obviously to get rid of inflammation. We have to get rid of the underlying factors, and a good phase 1 therapy is what gets your gingiva rid of any kind of inflammation. Okay, now let's move on to the other two main aspects, that is the thickness and the width. I'm going to be discussing both of these hand in hand. For me to simplify this to you, I have drawn this diagram. I'm going to show you what thickness, when I talk about thickness, I'm talking about biotype. And when I talk about width, I'm talking about keratinized tissue or attached gingiva. So when I talk about the thickness, this is the thickness of the gingiva. Okay, this red arrow, the first red arrow that has come is talking about the thickness of the gingiva or the biotype. If the thickness is less, we call it thin biotype. If it is big, we call it, if the thickness is greater, we call it a thick biotype patient. Okay. This, on the other hand, so thickness was buccolingual. This is apicocoronal. The apicocoronal dimension of the gingiva is the keratinized tissue that we're talking about. Okay, so keratinized tissue is basically the part of the gingiva, the outer part of the gingiva, which is keratinized, which has a keratin layer. Now, this usually extends from the gingival margin to the mucogingival junction. Okay, out of this keratinized gingiva or the keratinized tissue, the part of the keratinized tissue that is directly attached to the bone is called attached gingiva. I hope this clears the concepts for you. The thickness, buccolingual, is biotype. The apicocoronal dimension from the gingival margin to the mucogingival junction is called keratinized tissue. And that part of the keratinized tissue that is directly attached or pasted to the bone is called attached gingiva. If you are clear about these three things, you will understand the next steps more clearly. Okay, so now let's first have a look into biotype. What is the biotype? Like we said, biotype is the thickness of the gingiva. Okay, the buccolingual width of the gingiva on the buccal aspect of the tooth is the biotype. We have two types of biotypes, thin and thick. Now, how do you distinguish between the two thicknesses? There are lots of tests to do that, but the most simple test to do is called a translucency of the periodontal probe. What you do is you insert your periodontal probe into the sulcus of the patient. If your patient has thin gingiva, you will be able to trace the margin of the probe on the outside with the naked eye. If the gingiva is thick, you will not be able to see the margin of the probe. Now, usually, this test is called translucency of the periodontal probe. Usually, girls, women have thin biotypes, and males usually have thick biotypes, but it can always differ. Now, thin biotypes, if you have thin biotypes, your gingiva is more prone to recession. That means recession can easily occur in you. And whereas when you have thick biotypes, recession is less common, but pockets are more common. So you need to pay attention to what biotype your patient has. If your patient has thin biotype and you're going to place implants, you have to make sure that you thicken the biotype either before placing an implant, during placing the implant, or after the implant at stage 2, or later if you would like, to thicken the gingiva so that the implant remains protected. If you have thick biotype, that's wonderful. That's a good thing. But in some cases, you're going to have too thick a biotype. You will have such thick gingiva, like the case that I showed you, the fibrotic enlargement case that I showed you, such thick gingiva that it doesn't look good. So, biotype we do not want. Too thick a biotype we do not want. What we are aiming for is thick biotype. Okay. Now, if you don't have what you want, how do you treat it? If you have a thin biotype, what are you going to do? There are procedures. So basically, if you have thin gingiva, your procedures are going to aim to thicken the gingiva. That means you're going to augment the biotype or the soft tissue. To augment the biotype, you can do any of the following procedures. There are innumerable procedures, but to simplify, I've just put a few. So connective tissue grafts, that means you take a graft from the palate and you place it in the um, desired site. Free gingival graft. I'm going to tell you the difference between the both when we go ahead. Free gingival graft is again a graft we take from the palate and place it in the desired location. Soft tissue substitutes. If you do not want to take soft tissue from the palate and create another wound, you can buy these soft tissue substitutes such as mucografts and mucoderms, and those are membranes that you can use in the place of the connective tissue or free gingival grafts, but they're very expensive. Buccal roll is a very, very interesting procedure which we'll be studying ahead. And you can also give PRF injections into the gingiva. So these are ways in which you can thicken the thin gingiva or biotype. Okay. If you have too thick a biotype, if you have biotype like this, which is too thick, what are we going to do? I'm sure you all know the answer by now. You're going to resect it, you're going to thin it, you're going to smoothen it by performing a gingivoplasty. So when we perform a gingivoplasty, so there are two things you must have heard of: gingivoplasty and gingivectomy. To simplify it for you, I don't want to get you into the definitions and technical terms. To simplify it for you, gingivoplasty is when you reduce the thickness of the gingiva, the buccolingual thickness of the gingiva. Gingivectomy is when you reduce the height of the gingiva. Okay, the apicocoronal height of the gingiva. So if you remember it like this, it's going to make it easy for you. Okay, gingivoplasty. Plasty is basically reshaping. Reshaping, what do we reshape? We reshape the gums like we do when we do waxing and carving in our teeth sets. Okay, and gingivectomy is when you excise the thickness, excess gingiva. I'm going to show you cases on that. Okay, so I hope you've understood about the biotype. If you've understood about the thin and the thick biotype and how to treat and how to diagnose, then let's move on to keratinized gingiva. Okay, so keratinized gingiva is basically, like I told you, the apicocoronal dimension of the gingiva from the gingival margin to the mucogingival junction. Okay, now to simplify it, I'm just going to show you what it looks like in this image over here. If you can see my cursor, just try to follow it. This is the gingival margin. Okay, and as you go apically, you can see the gingiva is initially pale, and at one point it starts becoming pinkish. Okay, the point where the gingiva, the line where the gingiva converts from a pale pink firm gingiva to a movable reddish gingiva, that line is called the mucogingival junction. Okay. There are ways to diagnose it. You can take a periodontal probe and roll it on the gingiva. The movable part is going to, the reddish part is going to move, whereas the firm part is going to remain attached. It is not going to move. So distinguishing line between the two is called the mucogingival junction. But if you don't want to, if you want a very simple way of doing it, just assess the color difference. It's very easy to see. If you can identify the margin where beyond which the gingiva now starts looking red, that is where your mucogingival junction is. So like in this patient over here, yes. So the mucogingival junction goes abruptly like this. If you can follow my cursor, you'll be able to understand. That is how the mucogingival junction goes. So from the mucogingival junction till the gingival margin, we have lots of gingiva. That means this patient has a lot of keratinized tissue. That means this patient is going to be able to maintain his oral health very, very nicely. Okay. Now, when it comes to keratinized tissue, we have subtypes. Inadequate is when the width of attached gingiva or the keratinized gingiva is less than desired. Like in this patient over here, if you can follow my cursor, because this patient has gingival recession, the distance from the gingival recession, this gingival margin, to this mucogingival junction is very less. If you can follow my cursor, this is where the gingival recession is. This is where the patient's gingival margin is, and this is the mucogingival junction. So the distance is very less. So this is inadequate. You may have conditions where it is adequate. Okay, here we've built it up. So this is adequate. Now from here, the gingival margin goes down till here. This entire thing is red because it's newly formed, but the attached gingiva goes right from this point till this point. Okay, so that's adequate. And there may be cases where it's excess. When will I say it is excess? When it is covering the tooth. When the extra keratinous tissue is covering the tooth. Okay. So what are you going to do if you have adequate is what we want. If you have inadequate, you're going to perform surgeries to increase the width of the gingiva, the keratinized tissue. How are you going to do these procedures? You're going to do procedures such as free gingival grafts and connective tissue grafts and coronally displaced flaps and apically displaced flaps. Okay, so these procedures are going to help you increase the width of the attached gingiva. Okay. On the other hand, if you have excess keratinized tissue, like in this patient again, here the height of the keratinous tissue is so long, it is so long that the tooth is also covered now. So we don't want the tooth, it's good that we have good keratinous tissue, but we don't want the tooth to be covered. So here, what are we going to do? We are going to excise this extra gingiva so that the tooth structure is exposed. Now, when we excise the gingiva, that means we're going to be excising it in the apicocoronal dimension. When we excise in the apicocoronal dimension, that automatically means we're performing a gingivectomy. Like I told you, gingivoplasty is smoothening the thickness, gingivectomy is reducing the height. So this to treat patients who have excessive keratinized tissue, you're going to perform a gingivectomy. Okay, please excuse me for a second. Okay. If you've understood all of this so far, if not, please drop your questions on the chat box. But if you've understood this so far, I'm going to be showing you certain cases. But before you move on to the cases, um, I want to bring to your information the key to treating any patient or any gingival or periodontal patient or any patient in dentistry. Now, when a patient comes to you and you're absolutely clueless about what to do and how to begin the treatment, I would like to tell you to first try to identify what has caused the problem. Okay. So, unless and until you identify what has caused the problem and you don't treat that problem, the cause, if you don't treat the cause, if you don't treat the etiology, the treatment that you offer is going to fail. Okay, the treatment that you offer is going to fail if you do not eliminate the cause. So, okay, sorry. I have a question, but I'll take it after I finish this slide. Okay, so like I told you, your first intention is to try to identify the cause or the etiology. Then your second step is to eliminate the etiology. And once you've made sure that the etiology is eliminated well, then only go ahead and treat the patient. Okay, the three steps of treating the patient are identifying and eliminating the etiology, treating the defect once you've made sure the etiology is eliminated. And after this, something that a lot of us don't do is to maintain what we've treated or to put the patient on recalls or follow-ups, because unless we follow up we wouldn't know if our treatments have been successful. About 10 years back, I treated two patients. Patient A, in whom I thought the treatment is going to be successful, and patient B, in whom I thought the treatment is going to fail terribly. I saw the patients after 10 years, and what I saw was exactly the opposite. The patient in whom I had expected to succeed had a tooth that was almost on the verge of being extracted, while the other one, in whom I had placed an implant in a very, very compromised case, has had no bone loss after that. So these are the things you understand only on follow-ups. So it's very important to put your patients on follow-up so you understand what treatment you offer works and what doesn't work. Okay, so before I move on, if you've understood this, we'll be moving on to the cases. But before we move on, I have a question in the chat box, which goes as, how can we assess thin and thick gingival biotype in hyperpigmentation? This is an excellent question because um, it makes sense. But when you have thin gingiva, you're going to be able to trace the border. You may not be able to see the color difference between the gingiva and the probe, but uh, just so say you have this is your thin gingiva and you place your probe below it. So when you have the protrusion of the gingiva, the probe is going to very easily be seen. Okay, but when you have something very thick, when you have thick gingiva, it is not going to be seen. You may not be able to see the color difference, but you will definitely be able to see whether the probe is seen or not. Okay, and if it also depends on where you're going to be performing this. If it is around an implant, then you will perform procedures to thicken the biotype around implants. If you can see the implant, you will be able to see the translucency of the implant on the gingiva outside. Okay, there are other ways to also assess the biotype, but they are not very practical. Other ways to assess it is by trying to take an X-ray of the gingiva while keeping a radio opaque object on the outer surface and a radio opaque object on the inner surface, such as a GP point or a lead foil. So there are these other methods, but they're not very practical to do in the clinic during our routine practices. So just inserting the periodontal probe is going to give you an idea whether it's thin or thick. And that much is enough for you to understand whether to treat it or not. We are not trying to find the exact measurement there, but just to understand whether we have to treat the patient or not. Okay. Another method you can do is you can anesthetize the gingiva, take your endo file and pierce the gingiva, put the stopper. Once you remove the file, you will be able to see how much part of the gingiva went inside. So there are these methods as well. Okay, but the most practical is translucency of the periodontal probe. Okay, okay. So moving on to the cases. Now, this patient, let's try to identify what all are the problems here. Here, one problem with the tooth is extruded, it's not in a good position. So, to treat that problem, we are undergoing orthodontic treatment. So, there is a solution for every problem here. Then, you can see a bifid frenum. A high frenal attachment or an abnormal frenal attachment is going to be responsible for pulling the gingiva down. So that is one of the causes. So we have to make sure we eliminate this by doing a frenotomy. Okay. And then you can see that the gingiva is rounded. So the gingiva has some kind of inflammation. So we have to make sure we eliminate the inflammation, and the contour of the gingiva is accentuated. It's accentuated scallop. So we are going to try to reduce this as well. So this patient's treatment was ortho and perio together. The orthodontist was trying to intrude the tooth so that the bone support of the tooth would increase. And we as periodontists were trying to cover the root and make the gingiva more stable for to take orthodontic treatment. So in this patient, we decided to go ahead with a free gingival graft. So, what is a free gingival graft? A free gingival graft is a graft from the palate which has connective tissue and epithelium. Okay, FG has connective tissue and the epithelium. So, you take it from the palate, you prepare the recipient site, and you paste it onto the recipient site. In layman terms, this is what is done. Okay. Now you can see in the second image that we've prepared the recipient site. How do you prepare the recipient site? We've de-epithelialized. We've removed the epithelial layer. We've exposed the connective tissue so that when we take the graft and we place the graft on top of the recipient site, connective tissue facing downwards, the connective tissue of the recipient site and the connective tissue of the graft are going to unite to form one. Okay, that is basically the whole idea over here. You can see how the palatal wound looks like. Okay, after taking the graft, and in that picture, the second picture, you can also see that the frenal attachment has been shifted down now in the same procedure. Okay, so there's no bifid frenum anymore. This is the graft that was harvested. The uh, um, it looks like this, and it was sutured to the site. And this is an image of how it looks. We don't have a better image, it's by the orthodontist. Okay, so the orthodontist has also managed to change the alignment of the tooth. So the support of the gingiva has increased. Okay, that was to show you how a free gingival graft looks like. Now moving on to this case over here, in which now let's see the problems over here. This patient has attrition. This patient was had a habit of chewing tobacco, and that is why had generalized attrition. We most probably got rid of the habit or reduced it. Now this patient has recession, okay, and less attached gingiva in areas of recession. Apart from that, everything else looks fine. The gingival health is fine, everything else is fine. So in this patient, we attempted something called as subepithelial connective tissue graft. So free gingival graft is when you take a graft from the palate which has has connective tissue and epithelium. In in subepithelial connective tissue graft, there is only connective tissue. Okay, like the name suggests, there's only connective tissue. So the difference between FGG and SCT is that FGG has both connective tissue and epithelium, whereas SCTG has only connective tissue. It has no epithelium. Okay, the FGG when it was taken from the donor site, it was pasted onto the recipient site on top of it on the outer surface, whereas SCTG cannot be put. It isn't put on the gingiva but inside the gingiva. Okay, these are a few differences. Okay, the type of the graft, what it contains. FGG has connective tissue and epithelium. SCTG has only connective tissue. FGG is put on top, it is pasted on top. Like if this is the connective tissue, it is put on top of the recipient site, whereas connective tissue, SCTG, is put inside the sulcus or inside the gingiva. Okay, this is for you to understand. You'll get to know in the picture here. Now, image number one, pre-op. Image number two, this is a particular different type of procedure we performed where we made pouches and tunnels. It's called a pouch and tunnel, but you can see how I've lifted the gingiva from the bone over here. Okay. The third image is the tissue taken from the palate. Okay. This is the tissue harvested. Now, in the bottom left image, you will be able to see that the connective tissue, the graft, has been put inside the sulcus. It has been put inside the sulcus. Okay. Um, can we get rid of the annotations, please? Just give me 1 second. Somebody is making annotation on the screen, so yeah. Okay. So if you see in this image over here, you'll be able to see that the connective tissue is put inside the gingiva like that. Okay. And in this image, the right image, you'll be able to see how it looks after healing. Yeah, this is to compare both the images. So what have we done here? We have increased the height of the keratinized tissue in the areas of recession. That was the main intention, but you will be able to also see that in an attempt to do so, we've also ended up thickening the gingival biotype. If you can identify the difference between the two images, we've also ended up thickening the gingival biotype. This is the beauty of this procedure. Connective tissue and FGG both are very tedious procedures, but uh, connective tissue usually gives more predictable results than an FGG. Okay, now this case number 3. This patient has multiple recessions. If you observe her teeth carefully, there's slight recessions everywhere, especially on the upper entire arch. Now, to treat this patient, I will not be able to harvest so much connective tissue or free gingival graft from a palate to suffice the entire recession. So, in this patient, instead of doing that, we've used a substitute. Okay, so the treatment we've done here is coronally advanced flap with a chorion membrane, and I'll show you how it looks like. So, this is the pre-op frontal, left lateral, and right lateral. If you observe the teeth carefully, the teeth have slight recession everywhere. There are again annotations coming on the screen. Okay.
Somebody is making it, or it is fault of some.
Somebody's like I think it must be happening by mistake, but it's coming from somebody. Huh? Okay, so if you observe the teeth carefully, you will be able to see recession, especially in the upper arch, almost on all the teeth. Now, here what we've done is here in areas of recession, especially this canine, if you will be able to see the 1, 3, you will see there's almost no attached gingiva here. Okay, so this is the mucogingival junction, and there's almost no attached gingiva. So our intention was to increase the width of the attached gingiva or keratinized tissue and also to cover the roots in the same goal. Okay. What we've done here, we've done a procedure called as coronally displaced flap with chorion membrane. So we've taken a membrane, external membrane, and we've placed it, we've covered the roots, and we've pulled the gingiva coronally and we've sutured it. Now, if you see image number 1, you'll be able to see orthodontic brackets. We've put orthodontic brackets so that when we suture the gingiva at a coronal position, it remains there and it doesn't recede back again. So these are temporarily attached to the tooth, to the teeth. Okay. And the chorion membrane, you can see the chorion membrane is in place. And then we've sutured it. This messy structure over there is the membrane that has been exposed. Okay, so after doing that, we've sutured it, and the lower pictures are of the healed tissues, and you'll be able to see that the tissues have pretty much improved. Okay, let's compare both of them. The upper images are post treatment, whereas the lower images are pre treatment. If you observe carefully, you will be able to see that the recession has been covered, the roots have been covered in quite a few areas. So, this is how coronally advanced flap using a substitute is. This particular membrane that we used was not expensive, isn't very expensive, but the more reliable ones that we get, such as mucograft, are very expensive. So, okay, now coming to this case, let's see what the problems here are. In this patient, the gingival biotype is thick, too thick. The keratinized tissue is so wide that it has covered the root, the teeth, and there is also an excess pigment. Okay, hyperpigmentation. So in this patient, what we've decided to do is gingival contouring, in which we are going to do gingivectomy. That means increase the height of the tooth or reduce the height of the gingiva. Gingivoplasty, reduce the thickness of the gingiva, and a depigmentation in the same procedure. So, picture number one, pre-op, fibrotic gingival enlargement with hyperpigmentation. Picture number two is after the gingivoplasty has been or gingivectomy has been done. Okay, so you can see how the gingiva has been thinned out. And the picture number three is 6 months after healing. Like you all know that pigment is something that is very, it is genetic to us and it's difficult to eliminate the cause completely. So you do a yeah. So after a couple of months, the pigment starts coming back again. Okay. Okay. Now let's look at the problems over here. The gingiva is absolutely healthy everywhere else. It has a deep recession defect over here. Okay. And it also has a high frenal attachment. Now, this patient, what we've tried to do is cover the roots and at the same time increase the width of the attached gingiva. I'll show you the mucogingival junction. If you can trace my cursor, this is how the mucogingival junction goes. So the patient literally has no mucogingival junction. Okay, just 1 millimeter band probably. And that's why the patient was unable to maintain this area. So in this patient, we've done a free gingival graft to improve the biotype and keratinize tissue width and to expose the cover roots. Picture number one, top left, is preoperative. Picture number two is the recipient site which has been prepared by removing the epithelium, deepithelization. Picture number three on the bottom right side is suturing of the graft to the recipient site. And picture number four is after healing. Now, in this picture, you'll be able to see the inadequacies of a free gingival graft. Okay. Number one, we have not managed to cover the entire root here, but we have definitely managed to create a band of keratinized tissue, which is going to help maintain the health of the teeth. Okay, now another problem you'll see here is that the band of keratinized tissue looks different from the recipient site, and that is a big problem of FGG because you're taking a graft from the palate, which is a completely different site. You're suturing it to this site, and on top of it, it's always going to look different. So in aesthetic areas, it doesn't look that great, especially if that area is seen. So when it comes to like to grafting, soft tissue grafting, you must keep this in mind when you're going to do free gingival grafts. It's not going to look that aesthetic. So if aesthetics is a requirement in that area, then you can consider another procedure. Now, when you I'm assuming that in the future you will come to a point where you start doing these procedures yourself. Considering you're going to be doing it, or if you get such patients in your clinic and you invite a periodontist to perform these procedures, one thing you should know is that when you talk to your patients, always make sure your patient knows that the reason to do this is to create the band of keratinized tissue, and the second reason is to cover the roots. But the main primary reason is to create the band of keratinized tissue. Always tell your patients that we are going to, like, you can explain it in your own words. you're going to try to create a band of keratinized tissue. And while doing that, you're going to try to cover the roots as well. If you are unable to cover the roots, you may have to go for a second procedure in which you either do a procedure, the same procedure again, or you just do a coronally advanced flap of the gingiva that you've created. Okay, so this is how it free gingival graft looks. Okay. Now, this patient over here, we've placed implants, and the implants integrated well. The patient was given a prosthesis and all of that, and the patient kept getting food lodged on the buccal side of the prosthesis. And the reason was very clear to us. It was because the patient has no attached gingiva over here. So if you see, let me trace the mucogingival junction for you on the buccal side. This is how the mucogingival junction goes. If you trace my cursor over here, this is the mucogingival junction. So the patient absolutely has no attached gingiva on the buccal side, and that is one of the reasons why patients can't brush around the implants or the crowns, and the patient can't even eat properly because the food keeps getting rolled in that area itself. So in this patient, we decided to go ahead with a connective tissue graft. Okay. So what we've done here, picture number one is preoperative. Picture number two is the a single incision technique. It is through that one incision that we've removed the graft from the palate. I should have turned the picture upside down. So it's through that incision that we've removed the graft that you can see in the third picture. Okay, the third picture is of the graft that has been removed. This graft has only connective tissue, it has no epithelium. So when I place it in the recipient side, I can place it inside the gingiva and not necessarily on top of the gingiva. Okay, so here I've placed it on inside the gingiva. And picture number four is the suturing of the graft. Okay, so I've sutured the graft inside. I do not have post healing pictures of this patient yet. It's a fresh case, but this is to show you how connective tissue graft can be done around the around implants as well. Okay. Now we
Similar
can do
similar
we
cases there on the brochure.
oh yes, yes.
What do you say?
There are similar cases on the
Mm,
brochure.
yeah.
Okay. So I've spoken about an FGG, spoken about a CTG, okay, and now I'm going to tell you a very good procedure, something that I believe all of you will be able to pull it off yourself if you all are placing implants. If you all are placing implants and you want to increase the soft thickness of the soft tissue around implants, and FGG and CTG is too out of reach for you, and soft tissue substitutes are too expensive for you, you can go ahead with this procedure that I'll be explaining. Now, in this patient over here, you can see how deep the buccal the buccal ball is. Okay, so it is a very deep concave. Okay, so in this patient, we placed an implant in that region. We did two things to augment the tissues over there. While placing an implant, we've placed bone graft. I've not put that part of the procedure here because I'm talking solely about soft tissues. But while placing the implant, we placed bone graft and a membrane. That got us a little more structure over there. And then we've done the soft tissue grafting. I'll show you in this next image. So this procedure is called the buccal roll, and it is an excellent procedure. It's pretty easy to do compared to the previous procedures, but this is something you can do around implants. This procedure is going to help you improve the thickness of the soft tissues around implants and to protect the implants. So the earlier image that I showed you was before the implant placement. I'll show this image again. Try to note how deep the convexity was. Okay, the concavity was. This is how concave the bone was for implant placement. After implant and bone grafting, this is what we had managed to achieve. This picture over here. Okay, so the concavity is already reduced a little bit, but we wanted to make it convex because it's an anterior region. We wanted the gingiva to be as good as possible. So what we've done is something called as a buccal roll. Now in the buccal roll, what is done is the soft tissue from uh, um, can you see this incision? Just give me one moment. Yeah. Can you see this incision? If you can follow my cursor, this is the incision that has been marked. Okay, this slightly palatally, not on the alveolar ridge, slightly palatally, and a portion of the flap has been deepithelized. So a partial portion of this flap has been deepithelized. That means the epithelium has been scraped off. Okay. Then the flap has been raised and move on to the picture right below it. Okay. The flap has been raised and it has been tucked inside like that. Okay. I hope you've understood that. You raise a flap, a little bit of the palatal or the the flap has been rolled inside. Okay. This pinkish whitish part is the deepithelized area, and the area where you can see a little bit of pigment is not deepithelized. So we've tucked in the deepithelized part and then we've sutured it. Okay, this is right after suturing. Now you will be able to appreciate these two images and see how the concavity has not only become flat, but we've attained a convexity here now. Okay, that is the beauty of this technique. It's simple, easy to perform, and does not require any extra equipment, does not take a lot of time, and gives you instant and more certain results because you're not cutting off the blood supply like you're cutting off the blood supply in FGG and CTG. You're not cutting off the blood supply, you're just rolling it inside and suturing it. It gives you beautiful results. And you can appreciate in this image, this bottom left image as well, how the gingiva now appears thick over there. Okay, so this is a procedure I perform very routinely, and I'm just going to be showing you different cases. This image, the patient on the left, again, maxillary anterior region, in which this is my incision line. You can see the incision line. This is the flap that has been raised. Now here you'll be able to appreciate better the deepithelized part and the epithelized part. Okay, so the deepithelized part is tucked inside and it's sutured. And this is upon healing. So upon healing, you can see it has become convex. It was concave and now it's become convex. It just gives you instantaneous, more certain results. Okay, the image on the top center, again you can see how it was deep and concave, the bone over here, and all of this is after implants. The implants have been placed, and then we performed a buccal roll, and now after the buccal roll, you can see how the gingiva has become straightish and a little convex. Bottom center, you can see again maxillary anterior area, slightly concave. We did a buccal roll and we managed to achieve a convexity. I do not perform buccal rolls only in the anteriors. I also do them in all my posterior cases, almost all my posterior cases. So if you see the top left image, you will be able to appreciate this concavity. Okay. After doing the buccal roll, this is how the convexity looks instantaneously. Okay. And by doing that, by folding the gingiva on top of each other, on top of itself to create that, you're giving such a thick tissue over there that that thick tissue is going to protect the implant beneath it, even if there is bone loss around the implant. Okay, so this is a procedure that I do in almost all my patients unless it is not required. Now, this procedure you can perform either as a preparatory procedure before you place implants. You can do it before you plan implants to thicken the gingiva. You can do it while placing the implant. This first patient, leftmost patient, is the buccal roll has been done while placing the implant, and all the other buccal rolls I've done after placing the implant while doing stage 2 surgery. In stage 2 surgery, we open the exposed implant, right? So while opening that, I open it with a buccal roll so that in one surgery I've achieved two things. I've exposed the implant and I've also increased the thickness of the tissues around it. Okay. Okay. Then one of my so this case is to show you that this patient has a lot of keratinized tissue. Okay, lot of keratinized tissue. The thickness is also fine, it's good. But I wanted to increase the height of the crowns because this patient was huge. And for her personality, the teeth looked very small. So the keratinized tissue was in excess, and I wanted to reduce the height of it. So here what we've done is we've done gingivectomy to increase the clinical crown. Okay. So the bottom left image is her smile before doing gingivectomy. She basically had a gummy smile. Then in her, we've planned the we've planned the crown lengthenings. We've given the incisions, trimmed, reduced the bone, and this is the final placement of her flaps. And then this is right after the crown placement. There's still a little bit of inflammation in the gingiva, but that's the picture I have of her yet. And that is her smile after performing gingivectomy. Okay, now coming to the my last case of today. Um, Now this patient came to me, very young patient. She had mobile lower anterior teeth. Her lower anterior teeth were mobile, and you can see how the gums have gingiva has receded. She has been going uh, to visit doctors all her life, but there have been dentists who've told her not to get anything done because they've suggested that if you do something, then the gingiva is going to recede more and the teeth are going to start moving more. So this patient came to me. Will you be able to put in the chat box what do you think is the condition of the lower anterior teeth over here? What would be your prognosis for the lower anterior teeth? Can you put in the chat box, please? Okay. So I have somebody say grade 3 mobile teeth. Yes, that's how it looks like. It looks like the teeth are grade 3 mobile. Yes. It looks like there is mobility, recession. Very good. It looks like there is severe gingival recession. Poor prognosis, especially with the 4-1. The prognosis looks bad over there. Splinting. Yes, it looks like the patient requires a splinting. Yes. Does anybody feel? Yes. Okay, that's good. Thank you for these responses. Thank you. Does anybody feel that the prognosis of the teeth is going to be good? Okay. Okay. So, okay. Okay. That's good. That's good. Okay. So now when this patient came to me and she presented a history of years of having this kind of calculus and mobility and discomfort and bleeding from all her gingivas. I looked at the patient and, like I always do, I decided to give this patient a chance by doing a good scaling. Okay. So this patient is purely being treated by scaling and root planning. Okay, picture number one, top left picture is pre-operative, the same day after scaling. After scaling, you can see that it's not so bad. Okay, this is the top right images of the patient right after the scaling. Okay, and I recall the patient exactly after a week, and you can see just after one round of scaling how the gingiva has grown back again and the mobility had reduced almost to it had become grade 1. Okay, and after getting the patient in this situation, I have performed another round of scaling. Now I'm waiting for the patient to come back for a follow-up, and in my opinion the recession as the root is going to have be covered completely by now. So what looked very scary before going for scaling wasn't actually that scary at all. And the patient started feeling like for nothing she let the calculus just be there for so many years just because people were afraid to expose it. This is me trying to tell you that the best procedure you can do as a best periodontal procedure you can perform as a dentist is a very good scaling, because 90% of your patients are going to respond very well to your scaling. You do very good scaling and root planing. Of course, you plane the roots as well, and you're going to get extremely good results. This is just a difference of 1 week. And if now the patient has shown a sign that her gingival recession is reducing by itself. Okay, that this is her sign that have seen just after 1 week. So I don't need to perform any procedure now. I'm going to wait for a little more and a little more to see where her gingiva eventually settles down to. And only if required, I'm going to go ahead and perform any treatment over here. So this is me trying to tell you that I'm sure scaling is something each and everyone does well. So if you get complicated periodontal patients to your clinic, just without putting a lot of your brain, offer them a good scaling. Okay, do a good scaling and recall your patients. The teeth that are going to respond to your treatment are the teeth that are going to respond to your entire periodontal treatment ahead. Those are the teeth you have to preserve. There are going to be some teeth that don't respond, and those are the teeth that need to be extracted. All the other responsive teeth you can give them a chance. So this is what I usually follow whenever I get complex uh, patients in the clinic. I don't directly decide which tooth to extract, which tooth to splint, what to do. I just go ahead and do one good scaling. I call the patient again. I assess the teeth that have responded, the areas of the gums that have not responded, and that is how I plan which teeth to extract, which teeth to remove. Even if the teeth are grade 3 mobile, I've usually done that, and there have been cases where grade 3 mobile teeth have also reduced their mobility. So that is basically the beauty of scaling, which is a very, very underrated treatment. So with this, I would like to end my presentation for the day. And I think I've just completed on time. So thank you everyone for patiently being here, for responding so well to my questions, and for the questions you've asked yourself. And like they always say that a woman sets the tone for her home. If you keep the woman happy, you're going to have a happy home. I'm sure you've all experienced this, and you've all heard about this. That's exactly how the gingiva is. You keep the gingiva happy and healthy, and the gingiva is going to look after all your other structures of the oral cavity. And with this, I would like to end my presentation for today. Thank you very much for your patient listening. Thank you, the organizers, for giving me this chance. And if there are any questions, I'm free to take them.
Yes, after the wonderful presentation, we are here for question and answer. So anyone is having any question? Go ahead.
Yes. Yes. Okay. Thank you for this question. There's a question that says if after implant placement we realize that the tissue is thin or the biotype is thin, what can be done? So that's a good question. The tissue may be thin. Sometimes the tissue may not be thin, but the implant is placed so buccally that the tissues that there's literally no bone buccally, and that's why the tissues are just protecting the implant. In both these cases you can augment the tissues on the buccal side by like the procedures you can do. You can perform an FGG, a free gingival graft, or a connective tissue graft, or you can do the buccal roll like I told you. But if you have to perform the buccal roll, which is the easiest to master, you need to make sure you do it. The you can do it only if your implant is not open. Like the gingiva needs to be complete for you to raise that flap and tuck it in. So you can do it before implant placement, or if you've submerged the implant, you can do it after implant placement as well. Okay. I hope this answers your question. Okay. Then I have a question. Class 4 furcation, any treatment suggestions? So, see, class 4 furcation means a furcation in which um, there is a through and through bone loss between the roots of the teeth. The periodontal probe goes through it, and also you can see the furcation with your naked eye because there is no soft tissue covering it. That is basically a class 4 furcation. Now, if you have a class 4 furcation and if there is no mobility, so what I follow in my practice is if the tooth is not mobile, it shows no signs of mobility, and the patient wants to retain it, I retain it even if it is class 4 recession or if it's class 4 furcation. So I decide based on mobility. If the tooth is non-mobile and the patient does not want to extract it, wants to maintain it, then I recommend removing it. If the patient does not want to extract it, then I recommend I do not follow standard textbook suggestions where class 3 extract, sorry, grade 3 extract, grade 2 this, and grade 1 that. I usually try to decide patient wise and mobility wise. If there's no mobility and the patient wants to save it, I save it. If there is mobility and the patient wants to save it, then I recommend removing it. If there is mobility, if the patient doesn't want to save it and there is no mobility, it's a firm tooth, then we remove it. So I base my treatments based upon these two things. I usually get patients in my practice, or two different types of patients. I have patients who want to save their teeth, original teeth, no matter what. So in them, I tell them that we'll try our best and we'll give your teeth a little more life at least. If they're willing to go for that, we do it. And then I get patients who um, want a definitive treatment. So for them, I prefer extracting and replacing the teeth. How do we retrieve connective tissue with a single incision on the palate? Okay, so it's basically what is done is there is, if you can see this cast over there, here, I'll just try to show you here. So you make it a single incision, okay, you give a single incision, but you scoop out like you scoop out the tissue from inside the incision. It's a little difficult for me to um, show it to you on this cast now, but basically what we do is you make a single incision, then with your blade you dissect the tissues inside from that single incision, and you separate it from the bone below, and then you scoop it out. So it's a very uh, challenging technique. It's something which is very technique sensitive, but once you get the hang of it, it's possible to do that. So and the reason why we do this is so that the donor site remains it there's less morbidity for the patient. Okay, so I have a question: how can we save them? What perio treatments can we do on them? What are we talking about here?
Related to the previous question. She asked you one question above. Same doctor.
Okay, class 4 vacation. Right. Okay.
Related to
Right. So to save them, if there's no mobility, we save them. And the treatments you can perform, honestly, you can't do anything to build the periodontium back on a grade 4 vacation, class of vacation, but you can definitely maintain it for years if it is maintained well. So what you have to do is put your patient on an interdental brush so that the patient can brush the teeth the inside the furcation with the interdental brush, and by doing this it remains like that for years together. Okay, so there have been cases where it lasts like that for years. Okay,
any
I
more.
hope this has answered your question. Mhm. Bone graft, see, the problem with bone grafts is, Sakshi, so when you want to place bone graft, more the number of walls you have, easier it is to place. Like for example, I give you this glass and I tell you to fill this with bone graft. You can fill it to the brim with bone graft. So if you have such defects where you have a nice cup shaped defect which you can properly fill, you will get excellent results. But say I give you this platform and I ask you to build on top of this. Now, um, since this is a flat surface, no matter how much bone graft I put on it, it is going to keep flowing down. It's going to keep sliding down because I don't have any walls to hold it. So, usually in horizontal bone defects or in class 4 furcations, class 3, class 4 furcations, it's gone to that stage where it's very difficult to build it back from nothing. But if you have any cases, I think we have a WhatsApp group, and if it's okay, you can put your questions, clinical pictures, or X-rays of your patients onto the group, and I'll tell you how to treat that. Because a lot of times, what I think as a grade 4 furcation and you think as a grade 4 furcation could be different. That happens a lot. So it's a very subjective term. I may think it's grade 2 mobile, you may think it's a grade 3 mobile because it's very difficult to settle on one understanding. So if you have any particular cases, you can put and I can tell you what has to be done. Okay. So in a pregnant woman patient has mobility with anterior tooth, what will be the treatment plan? So if try to figure out what is causing the mobility, okay, and try to figure out what trimester the patient is in. If the patient is in the first the trimester, just avoid treating because any slight bit of stress is going to can induce labor. So try to avoid the treatment altogether. But if the patient needs something and it's bothering her, you can, okay, second trimester. So second trimester is fine. You can go ahead and treat the patient. What you can do is temporarily just splint the teeth. Just put a temporary fiber splint on the palatal surface and let it be. Let her get through with her pregnancy and then you can go ahead and treat her. Because if it's you need to figure out the cause for it. If you can tell me the cause, if you know, then I can help you with the treatment. If there's calculus and and inflammation, you can do a good phase 1, it's going to improve. If it's bone loss, you don't get into anything now, just put a splint and let it be. Okay. So even patients who've had very deep recessions, if there is no mobility, they last for years together. So that's something I follow. So you can do that as well. Yeah. Okay, patient on antihypertensives, how to take care of the gums. Will you be able to specify if the patient inflammation or calculus, like what part of the gums? Like, because you can definitely do a good scaling. Bonding to with the tooth, yes, yes. So for the splinting effect is in relation to the yes, you can definitely bond the teeth.
Dr. Haritma Nigam, she presented a webinar recently, 171, on AI
Okay.
in learning for academicians. She is saying wonderful webinar.
Right. Oh, thank you so much.
So it was a very wonderful webinar and excellent pictures, stunning uh, pictures and photography and documentation. Truly deserving to be called as the pink specialist in dentistry as a periodontist. Definitely, no doubt about it. For your cases and documentation, as well as your teaching skills. You're a great teacher, no doubt about it. And members and doctors, I would like to tell you, I have discussed few cases with her. She explains very well. You can put your cases in the group. That group will be there for discussions. And there is announcement for certificates as well as Dr. Sucheta, let me tell you, there were Malaysian dentists also because we have tie-up with Malaysian Dentists Association. So Dr. Sampurnam was there. I think he has left. Otherwise, I would have asked for a feedback from him. But in the group, you will get the feedback. There are more dentists who attended this, as well as this. The recording is done. So I hope you are giving consent for the YouTube video to put it on YouTube channel.
Absolutely. Absolutely.
More people can watch it, learn from you, and
Most definitely.
back to you also. For now, we are not allowing Pakistani dentists to be part of the ADC group. Previously, they were, but they are allowed to watch the video on YouTube channel. And they
Okay.
can learn. So I send the links to them, but I don't add to groups and I don't allow to Zoom meeting. But Malaysian
Okay.
are there who have already attended today's your webinar.
Mm-hmm.
I hope you get a invitation from Malaysia.
That would be wonderful.
That president
Thank.
is there. I'll tell him about you, as well as about the certificate for participants. I am once again telling you with a humble request uh, few things you have to do that registrations are done by you, obviously, all of you, whoever attended today. 41 was the count who attended from the beginning. Of those, few have put the brochure on Facebook and Instagram, like Dr. Smita had put, Dr. Ketki Narade had put. So many others are there who are asking for it. But I simply and very humble request to you that if you follow the rules, then only it is possible from our side. So again and again, in every webinar, I will tell you, if not this, next webinar is there where you can try complete all the protocol which is told to you for getting the certificate, and then only we will be providing the certificate to you. So whoever have followed the protocol will get the certificate in person. I will send them signed by Dr. Sucheta Vanjari ma'am and on behalf of ADC, Academy of Dental Careers. So next webinar is ADC 175 to be presented by Dr. Ashwini Vadne on transalveolar extractions. One more thing, ma'am, would you like to present more webinar for implants because you're excellent in this field? So can we have a date in future? Like I
Yes,
think today
absolutely.
you're not feeling well also, still you presented. You not looking well.
So,
Maybe some viral fever or something, but
mm,
2, 3 months or some 6 months, anytime I'll take time from you. So because people are asking for that, it's
absolutely.
good to know and learn for implant.
I would definitely like to do that.
Okay,
Most definitely.
okay,
Thank
thank you.
you.
Have a good time, you and Dr. Liu.
Yes,
Best
thank you.
wishes to both of you and
Yes,
your
thank you.
clinical practice.
Thank you so
Thank
much.
you, everyone. Thank you. So it's end of the webinar. I am ending the meeting. Thank you. Have a
Okay, okay.
Bye bye.